and Secretary of the Glaucoma Society of India from 2001 to 2002. Professor Pandav did his glaucoma fellowship from the Royal Perth Hospital, University of Western Australia, Netherlands in 2004 to 2006, and he was also the visiting professor at the Centre for Eye Research, University of Melbourne from 2014 to 2016. He was recently awarded the Gold Medal by the Bombay Academy of Ophthalmology in 2019 for significant contributions in ophthalmology. And also recently, he was awarded the Gold Medal for the Best Publication by the Indian Journal of Ophthalmology. He has numerous publications in peer-reviewed index journals. He is a great researcher, and he's presented over 250 talks and presentations in various meetings and has contributed 13 chapters to books. Our moderator for the evening is Professor Sushmita Kaushik, who's also a professor of ophthalmology in the glaucoma services at the Advanced Eye Center. She has a special interest in childhood glaucoma, and all who know her passion for childhood glaucoma and avoiding blindness. She is also specially interested in clinical applications of newer diagnostic tools, glaucoma surgery, and angle closure. She is the founder secretary of the Indian Pediatric Glaucoma Society, Vice President of the CHANDIGARH Ophthalmological Society at present, and former Secretary of the GSI. Ma'am has 130 publications in reputed international and national journals, close to 35 chapters in various glaucoma textbooks, and has authored the glaucoma section of an OCT atlas. She was awarded the best paper in glaucoma at AIOS in 2020 and also by the UK Pediatric Glaucoma Society in 2020. She was also honored with the Dr. D.B. Chandra Award for the Best Glaucoma Paper at AIOS in 2008 and the Best Scientific Paper in GSI at 2004. And she is a reviewer for many reputed journals, including the IOVS, Ophthalmology, AGO, VGO, and IGO, to name a few. Next up, we have Professor Suresh Kumar Gupta. Sir is heading the Department of Ophthalmology at the Government Medical College and Hospital in Chandigarh. He did his MBBS from Government Medical College, Chandigarh, and his post-graduation from PGIMR in Chandigarh. And his research specialization is in glaucoma and cataract. Professor Suresh has been the office bearer of various scientific bodies and he's been the immediate past president of the Chandigarh Ophthalmological Society. He was the coordinator of the GIEP of the Glaucoma Society of India from 2016 to 2018. He has been both the secretary and the treasurer of the North Zone Ophthalmological Society as well as the Society. And he also has numerous publications in international and national journals as well as book chapters. Another very dynamic glaucoma person is Professor Parul Ichpujani, who's working as a professor at the Department of Ophthalmology in Government Medical College and Hospital, Chandigarh. In addition to glaucoma, she is also taking care of the neuro-ophthalmology services there. She did her glaucoma training from the Advanced Eye Center PGI, which was followed soon after by a clinical research fellowship under Dr. George Spaeth himself at the Wills Eye Institute in Philadelphia. She is a member of the Associate Advisory Board and Education Committee of the World Glaucoma Association. Dr. Parul is also the Associate Managing Editor of the Journal of Current Glaucoma Practice and an Assistant Editor for the Glaucoma section of the IGO. She was enlisted in the Power List 2015 of the Best 40 Ophthalmologists Under 40. She is the editor of a series with Springer titled Current Advances in Ophthalmology, which is a great series for postgraduates. And she has close to more than 100 publications actually in research articles and book chapters in various national and international journals. Professor Srishti Raj is a professor at the Glaucoma Services of the Advanced Eye Center. He also did his post-graduation from PGIMR, and he has more than 12 years as faculty in the experience of more than 12 years. He has 40 publications in international and national journals, more than 100 presentations at different fora, and he is also a reviewer for various journals including the ACTA, Clinical Ophthalmology, Scientific Reports, Eye and Vision, and Seminars in Ophthalmology. Dr. Amandeep Singh did his MBBS and MD Ophthalmology from the Government Medical College and Hospital, Patiala. And he has his own practice since 2004, the Dr. Amandeep Singh Eye Hospital at Kharar. He has a special interest in refraction, cataract surgery, glaucoma, and neuro-ophthalmology. And all of us who know him know his keenness on ever learning new things. Next is Dr. Faisal, who's an assistant professor at the Glaucoma Services of the Advanced Eye Center. He did his post-graduation and senior residency both from the Advanced Eye Center and slid very smoothly into the post of faculty after that. And he is somebody who's again very interested in research. He's presented in various international and national conferences. He has 25 publications in national and international journals. And in the last year AIOS, he was awarded with the Dr. D.B. Chandra Disha Award. Our last discussant for the day, Dr. Deepika Dhingra. She is working as a consultant at Shah Satnamji Specialty Hospital, Sirsa. She did her MS Ophthalmology again from the Eye Center, which was followed by a full 3-year senior residency in cornea, cataract and refractive services. Later on by a 1-year glaucoma fellowship from PGI itself. So in the true sense, she is a comprehensive anterior segment ophthalmologist. And I don't think she's left any exam unclear. She's cleared the DNB, the FICO and the FICO. And she was also, she won the Best Pre-Paper and Best E-Poster Awards at the annual conference of CHANDIGARH Ophthalmological Society in 2019. And last but not the least are our future glaucoma stars who hope will do good things in the field of glaucoma. Dr. Gaurav is, again, after 2 years in cornea, cataract and refractive surgery, he's pursuing the glaucoma fellowship. Dr. Madhuri, Dr. Sagrika and Dr. Suman are senior residents working in the glaucoma services at the Advanced Eye Center. And Dr. Aarti and Dr. Ekta are working as senior residents at the Government Medical College and Hospital, Chandigarh. So with that, I think we are all looking forward to an extremely interesting webinar, and I will hand it over to Professor Sushmita for the rest of the proceedings. All yours, ma'am.
Thank you, Chintan, for the kind introductions and kind words for all of us. We know glaucoma is considered a silent thief of sight. And we thought an important aspect of everyday ophthalmological practice would be how not to miss glaucoma. And that really is the crux of today's program. So without further ado, we'll kickstart it by a keynote lecture by Professor Pandav. And then we'll have interesting everyday cases and which illustrate how we could pick up subtle glaucoma signs and not miss the dreaded problem. So Dr. Pandav, to you, sir.
Thank you, Chintan, and thank you, Chandigarh Ophthalmology Society, for this talk. And let me share my slides. Where are my slides? How do you share? I can't seem to get there.
There will be a share screen icon at the bottom, sir.
It's there, but it's not showing my presentation there. It's not showing my slide actually. I'll try again.
Have you opened your slides on your desktop?
Yeah, it's open on the desktop. So I'll try again. Yeah, it's coming now. Okay. Can you see my slide now?
Yes, sir, it's visible now.
Yes, sir.
Okay, so I'll go to the presentation mode. Can you see it now? Is it visible?
Yes, sir.
Okay, great. Okay, so today we are talking about how not to miss glaucoma in our practice. Now, this is very important because we know glaucoma is a blinding condition and it leads to permanent blindness. There is no cure for this. Therefore, it is very important to diagnose it in time, and so that you can intervene early enough to preserve vision, because we know the glaucoma treatment is known to preserve vision and it can prevent blindness. Before I go further, a bit of a status check of what is happening. We have about 12 to 13 million people in India who have glaucoma. But if you want to dig out these patients, you really want to get to them, you have to screen a lot more patients basically you had to screen everybody who is at higher risk, but it's estimated that close to 40 million people you had to screen before you can actually get to these 12 million. But the resources are limited. There are problems with the infrastructure, there are problems with the trained manpower. And if you look at the glaucoma specialists, there are not many in this country. If you go by GSI membership, then there are somewhere around 1,500. So that means a lot more actually is required from glaucoma manpower point of view. And that also means that a lot of glaucoma management would be done by comprehensive ophthalmologists or other ophthalmologists who are in cornea or in other anterior segment and even retina people. So everyone has to be on board as far as glaucoma is concerned because the workload is so much. It has some other implications as well because whenever you see a patient and from glaucoma point of view, that may be the only opportunity the patient has actually to get his glaucoma detected and treated. And if you miss it, then probably the next time he gets an opportunity to be with you might be a very many number of years, and by that time the damage might have happened. And it also has implications at the community level because of a lack of awareness and lack of education in the community. 90% of glaucoma cases actually are not diagnosed. So that means if you really want to not miss glaucoma in the community, the most important thing is to have a very robust public education program for glaucoma. So that actually is very important. The other issue is the misdiagnosis is very common, and even at the individual level, when the person is going to a healthcare worker or a doctor or an optometrist, it has been seen. I think this data is from a very large population-based survey from Arvind Group, that half of the glaucoma patients in their series who the newly detected glaucoma patient, they actually had visited a healthcare worker, a doctor, for the eye examination, and glaucoma was missed. So that means we need to do a lot more here also in terms of educating the physicians to treat glaucoma. The question is that why do we miss glaucoma? And that's the obvious question. And this question is what is answered partly, at least, by Chennai glaucoma study, which has again a very large survey done at Shankar Netralaya. And what they found was that this is basically because of the lack of good clinical practices. So as an ophthalmologist, so many of us don't follow what is known as a GCP. And the important thing that came out of that study was that lack of gonioscopy and lack of optic disc evaluation as a routine practice in patient management, in patient examination was not there. And as a result, a lot of glaucoma was missed. And that actually makes sense because if you're depending only on intraocular pressure, so it is believed that half of glaucoma patients would be missed if you diagnose glaucoma just based on intraocular pressure, and that's probably is what is happening here. So that means we need to strengthen our physician education programs as well. So overall, if you look at overall perspective, the best thing to do to stop people going blind from glaucoma is actually to have a lot of education in different levels. But the larger question we are addressing today is how not to miss in your own practice. So I think that is as an individual practitioner, when the patient comes to me, what steps I should take so that it doesn't miss. Now, since glaucoma is a silent disease, I think the short and crisp answer to it actually is the best way not to miss glaucoma is to examine the patients carefully. Because the diagnosis of glaucoma is a clinical diagnosis. So the investigations, whatever you have, OCT or visual fields or HRT or the latest things, it is only applicable once you have decided that this particular patient needs further investigations. And to reach to that point, you need to have a good clinical examination. And as also pointed out earlier, the good clinical practice here is very much required. So to this end, I'll give you some, I have some, you can say some tips to, use in your clinical practice so that you don't miss glaucoma. And I just put them like in 6 different categories. So there are 6 tips for not missing glaucoma in your practice. You can call them 6 pearls if you like them. And those 6 tips are, the first one is that never miss an opportunity to do opportunistic screen. Now, since glaucoma screening is not a very effective way of detecting glaucoma in the community, the best way is actually to use the opportunity whenever the patient comes to you. Make sure that you treat patient for glaucoma, because when the patient comes to an eye doctor for a reflection or for some irritation in the eyes or some other problem, glaucoma is not there in his mind. So unless someone looks for it, the glaucoma will be missed. So all patients, now it's very hard to screen everybody. So the next question would be that who is to be screened, and that is the next tip. So next tip is basically that you do some kind of a glaucoma risk profiling would be needed for all your patients. So anyone who comes to your clinic, see whether, where does it fit into the glaucoma risk score or glaucoma risk, assessment. So you can, roughly say that is a low risk or moderate risk or high risk. So depending, and here the 2 most important things are the age and the family history. Of course, you have other factors as well. But if person is less than 40 years of age, then the risk is low. 40 to 60, I would say the risk would be moderate, and after 60, the risk goes up, because we know that glaucoma is an age-related problem. So you have to relate the risk to the age. And family history again is very important. So if there's no family history, the risk would be low. If there's some distant relative, maybe moderate risk. But if you have a close relative like a sibling, then the risk is higher. It's almost 10 times the normal person. So this way you could classify them into some kind of a risk profile. If the patients are myopic, they're at higher risk of developing glaucoma. If the cornea is thin, we know there's a risk factor for glaucoma. And other than that, you have to look at other ocular conditions, uveitis, trauma, previous surgeries, use of steroids, systemic conditions like cardiovascular diseases, diabetes. Now, all these diseases will add up to the risks. So depending on the patient's profile, if you have more of these conditions, they will go to the moderate to higher risk category. Important thing is that there's no mathematics here. There's no way, and there's no algorithm which will give you the right risk. So you have to go by the presence of, these parameters to say that the risk is low, moderate, or high. And once you have a moderate or high risk, those are the patients who really need to be screened. Low risk, you may not screen them for glaucoma at that point of time, but subsequently at some stage they also need to come back. The third tip would be to follow the good clinical practice, which I have already talked about this, but this is very important because these need to be, you can't really overemphasize this. So the gonioscopic and disc evaluation must be a routine for all glaucoma, all patients that you want to screen for glaucoma. Of course, you will do other things also. You will check for IOP, central corneal thickness, and detailed anterior segment examination. But without gonioscopic and disc evaluation, you are going to miss glaucoma in half of the people that come to you. And also, there might be some difficulties in the assessment of the optic disc. Small people, cataract, uncooperative patients, but you have to understand, you have to be patient and persistent, and take appropriate measures. You dilate the people if need be, call the patient again if need be, but a good examination must be done for all patients as not to miss glaucoma. The fourth important thing is the optic disc evaluation, because that is the key. Most of the glaucoma patients in real life, they actually get detected when you look at the discs. Even if you have not seen intraocular pressure, you will still pick up glaucoma, especially moderate to advanced glaucoma can almost always be picked up by a good clinical examination. It's only the early disease which may be missed if you're not careful. So optic disc evaluation actually is the key skill which will give you a diagnosis. And it makes sense because there's a reason that optic glaucoma is actually defined as an optic neuropathy. Sometimes it may be difficult to ascertain whether there is glaucoma damage or not. That's the reason. That's why, because the optic discs, they come in very different shapes, sizes. Anatomically they might be very different. So you need to look at more these patterns. So the important thing is to understand basically the the anatomy of the optic nerve head. So if you are familiar with the anatomy of the optic nerve head, and if you can relate different structures like neuroretinal rim, so the relationship of the neuroretinal rim with the adjacent sclera, with the lamina calvarosa, and what are the structures visible, the blood vessels, and how the disc is placed, is tilted, rotated, collimatus. So all those things, when you have to keep it, if you can understand the anatomy of the optic disc, then it becomes easy to decide whether there is a possibility of glaucoma, is there evidence of damage, or there's no evidence of damage. So that is important. There are many ways to look at the optic, to examine optic nerve head for glaucoma, and in your textbooks you will find different signs are there, and there are DDLS, and there are other methods are actually there. But my simple approach is that look for what is most important. So in the optic disc, when you are examining for glaucoma in the optic nerve head, the most important thing from vision and from glaucoma point of view is the neuroretinal tissue, the neural tissue. And the neural tissue is actually represented by the rim, neuroretinal rim, that's where we see in the optic disc, and the nerve fiber layer. So these are the two things that you have to focus on. So the disc appearance may vary, but if you focus only on the rim tissue, then you will be able to say, as depicted here, like there's a lot of peripeprial atrophy here, the cup is shallow. But if you delineate it more carefully, you'll see there's enough the neuroretinal rim, which is a regular, the disc size is a bit large, so a rim appears to be on the thinner side, but this kind of a rim tissue is quite compatible with a good vision, with a normal vision. And on the other hand, if you look at the disc piece on the lower left corner, you see there's a neuro tissue is visible, but superiorly and inferiorly at the poles, the tissue is missing, and you also have a nerve fiber defect there. So there are many different patterns which glaucoma disc would show, and once you start looking at these patterns over a period of time, you get more experienced and become familiar with these glaucoma patterns, and then they become easy to recognize. So a lot of emphasis, I would say, should be placed in the optic disc evaluation. The next important pearl would be to be aware of glaucoma, the common errors that one makes when you are looking at the optic disc or when you are trying to evaluate patients for glaucoma. Now, these errors could come from in many different ways, like the failure to consider. So you have to, to match the anatomy and the neural tissue that you are looking at. So if the disc size is not properly assessed, or if you don't take a note of it, then we know that the larger discs, there's a tendency for overdiagnosis. So you could overdiagnose glaucoma if you make an error in estimating the disc size. And on the other side of the spectrum, if the disc is small, you're likely to underestimate. So that you have to be aware that if the disc is small, there's more probability of underestimation. And if the disc is large, there's more probability of overestimation. So that has to be known, and the disc finding be interpreted in that context. But more important, I think, from missing or underdiagnosis point of view, missing glaucoma diagnosis point of view, is the missing of subtle changes in the neuroretinal rim, like a small notch or a nerve fibular defect which is there, or a disc hemorrhage. And it has been shown in many publications that if you miss these conditions, you are more likely to miss underdiagnosed glaucoma as compared if you are more careful. Now, in this picture on your lower left, lower right, you can see if you look at it casually, there's enough rim tissue there. There's a good amount of neural tissue there, normal size disc. But inferiorly, there's a subtle change in the rim contour, and that if not seen clinically, and also there's a nerve fibular defect there. So if you miss this pattern of a little change on the rim tissue, and alongside you have a nerve fibular defect, is very, very typical. If you miss it, you're going to miss glaucoma. But if you see this, then you don't need any investigation actually to say that this patient is glaucoma. Even if your visual field is normal, you will still be, glaucoma would be a very high possibility. Then, of course, you have the peripeprial atrophy. This can also act as a confounder at time. We know that there's an association of peripeprial atrophy with glaucoma, and most glaucoma patients, they have some peripeprial atrophy, but not always. And not all peripeprial atrophies means glaucoma. But it has been seen that, I think we had a data from a very large series, like 5,000 patients, and we saw that peripatetic atrophy is an important indicator to to look more carefully for at the disc. But at the same time, PPA also tends to bias you a little bit because there's association with the PPA and the glaucoma. So sometimes it biases you towards overdiagnosis of glaucoma. So that also we have to keep in mind, because some of these things which have well established association, if that is present, then you tend to diagnose glaucoma even if it may not be there. So I think those biases also we have to keep in mind. And the sixth important is the tip, I would say, is that be aware of the frequently missed glaucoma phenotypes. So there are certain types of glaucoma they are likely to be missed. So if you have a PUAG, the IOP is high, mostly it's high. If you have acute glaucoma, you will find it in their most secondary glaucomas, they have high pressures, so they can be picked up from high IOPs. But angle closure glaucoma, for instance, in early stages before it has gone to a chronic angle closure state, it may be a angle closure which is getting intermittently getting closed. So you have a rather than a persistently high IOP, you have a situation where the IOP is fluctuating widely, and that can, so when you see this patient in the clinic, the pressure will be normal unless you have examined thoroughly the optic nerve head and everything, you're likely to miss it, and the patient will come, some months or years later with a nerve damage. Similarly, normal tension glaucoma, they have normal pressures, and unless you, and their disc findings also not as, they may be a little different from the normal high pressure glaucoma type that you see. So if you're not careful, you can miss normal tension glaucoma is again gets ignored. Pseudoexfoliation syndrome, we know that there's a high propensity, there's a high association of glaucoma with pseudoexfoliation syndrome. But many times when you see this patient on clinically, the pseudoexfoliation may not be apparent. You do gonioscopy, it may not be apparent. Once you dilate these people, and you can see there's a pseudoexfoliation material on the lens surface. You can see. So again, a careful anterior segment examination is required for some of these conditions like pseudoexfoliation, pigment dysplasia syndrome, and many other conditions actually which have anomalies in the iris, the peripheral cornea. So there are a number of conditions they can be picked up by a careful clinical examination. But be careful particularly about that there are certain conditions which are likely to be overlooked unless you have done a good clinical examination. So to summarize, glaucoma is largely an undiagnosed condition, especially in India. Like 90% of cases we are supposed to be not undiagnosed. Missing a diagnosis even after an examination is common, is not unusual, and half of glaucoma patients probably they are not picked up during a routine examination. So that actually is very important and underlines the need for continued education. Pay attention to the risk factors, individual risk factors. So if so that means some kind of a risk stratification or profiling is required for glaucoma patients. It's very important to do a good clinical examination so that you don't miss anything. And optic nerve evaluation is the key skill for glaucoma diagnosis, and that must be taught and must be learned by everybody. And also be aware of the pitfalls or the errors that we make in glaucoma diagnosis and what their impact would be on glaucoma progression or diagnosis and subsequently on patient's life. So with this, I think I'll summarize. With summary, I'll hand over to the moderator. And thank you very much for listening. Thank you, CUS, once again for giving this opportunity to share my views on the topic. Thank you. So if any questions, I will be happy to answer. And actually, we have designed this program in a way because I have given the overview of, how not to miss glaucoma. And subsequent cases probably will highlight some of the issues actually which we have spoken about.
Thank you, sir, for highlighting everyday situations of how not to. I don't see questions in the chat box, so the audience can either put in the chat if you join from Zoom, and I understand it's also on Facebook, so we do have another portal open for that, so you can put in your questions and we'd be happy to answer. So since we don't have anything right now, I think we'll go on to the first presenter. I invite Dr. Suman to present her case, and her discussant will be Professor Shrishti at the end. But Dr. Suman, over to you. Are you logged in? Yeah, Suman, you can go ahead. We can see your slides. You can share them. Yeah.
Thank you, ma'am. Good evening, everyone. I thank COS for this opportunity. I'm going to discuss about the management of glaucoma in post-LASIK eyes, and diagnosing glaucoma in post-LASIK eyes is a difficult situation. So, coming to my case, a 40-year-old male, he presented to our center in July 2017. He had history of raised intraocular pressure from outside, so he came to PGI for second opinion. He was a known case of myo, and he had history of LASIK in 2007 from outside, followed by raised intraocular pressure, which was managed conservatively with topical anti-glaucomas for nearly 1 month. Then the anti-glaucomas were stopped. His pre-LASIK CCT central corneal thickness in right eye was 640 microns, and in left eye 646 microns. There was no other significant ocular or family history. On examination in 2017, his uncorrected visual acuity in right eye in both eyes was 6/6, and intraocular pressure on Goldman applanation tonometry in right eye was 24, and in left eye 28 millimeters of mercury of medications. His LASIK flaps were in situ, and on gonioscopy, the angles were found to be open. And his central corneal thickness post LASIK in right eye was 543, and in left eye 556. On disc examination, disc in both the eyes was normal in shape, normal in color, contour, and cup disc ratio in right eye was 0.3 to 4, and in left eye it was 0.5 to 6, with the presence of disc asymmetry, and also there was presence of tilted disc in left eye, and also there was presence of disc hemorrhage in the inferior quadrant of the disc, which was missed at that time, and the provisional diagnosis of ocular hypertension was made. Then on red-free photograph, there was no RNFL defect in both eyes, but the disc hemorrhage in the inferior pole in the left eye was visible, but it was missed at that time. Visual fields in right eye was within normal limit, and in left eye there was presence of single scotoma in the superior quadrant. And on OCT RNFL, there was presence of inferior thinning in left eye. Right eye RNFL was normal. So patient was was kept under observation and was followed 6 monthly. These were his intraocular pressures from 2017 to 2019. They were in both eyes were below 22 millimeters of mercury, and on last examination on 6th of Feb 2020, in his right eye IOP was 27 millimeters of mercury, and left eye was 29 millimeters of mercury. These were his IOP trends in both eyes. Red is the right eye and green is the left eye. So these were always below 22, and on last examination in Feb, the pressures were raised. So at that time, right eye disc there was no change was noted, and in left eye there was cup disc ratio increased to 0.7. Also there was inferior rim thinning, And on red-free, right eye RNFL was normal. In left eye, there was presence of RNFL defect along this vessel inferiorly. On visual fields, in right eye, it was normal, and in left eye, the superior scotoma, which was seen earlier, it was not present, but there was presence of new scotomas in the nasal area. On glaucoma progression analysis, there was no progression detected in both eyes, but on OCT RNFL, there was structural progression seen in the inferior quadrant. It changed in the left eye from yellow to green, yellow to red. So the final diagnosis of primary open angle glaucoma was made in the left eye, and right eye, it was ocular hypertension, and patient was started on both eye travertin. It was started in right eye because the pressures were high, and patient also had the history, was a high risk as he was a myope, and also there was progression seen in left eye. So he was started on travertin in both eyes. Thank you.
So the discussion point here, Dr. Srishti?
Yeah. So the main problem in post-registration is the measurement of IOP. Which instrument is the best, whether Goldman or any other? So this is open to the house to discuss which tonometer we should use. And if Goldman is used, which area we should do it. So any question from the audience?
Would the panel like to comment? Any comment on the case, Dr. Pandav?
I think this case is very, very instructive and very illustrative. As I said, that how not to miss glaucoma, and in that I told you that there are a few findings which are often missed, and this patient actually had those findings. Like he had a small hemorrhage. If you look at the first picture, there was a small hemorrhage which could have been missed on a clinical examination. On this photo is difficult to miss, but on a clinical examination, because that's a resolving hemorrhage, that's not a fresh hemorrhage, that's a resolving hemorrhage. And that hemorrhage was missed at that time. Now, if that hemorrhage was picked up at that time, the diagnosis would have been made, that many years earlier. The other important thing in this patient is that this patient actually had a high pressure to begin with. Whatever the first record shows, the pressure is actually high, but that was attributed perhaps to the increased corneal thickness, because the corneal thickness is also high. So there's another important thing to realize here is that corneal thickness definitely is associated with higher pressure, but even in presence of the thicker cornea, you could still develop glaucoma. That IOP may or may not be a contributing factor. There may be other reasons which will produce glaucoma. But sometimes we get, I think this is a bias that we developed over a period of time, because we know that the corneal thickness is high means high pressure means it's not glaucoma. So that's what the textbook teaching or the general belief of the teaching it. But that also biases against us against giving or entertaining a correct diagnosis at that point of time. So that the reason is very important that you keep your mind open, even if your pressure is high. That explains your IOP, but still other things might be happening because his optic nerve can get damaged, that damage could be independent of IOP. So that might actually be happening in this patient, that it may, this change in the optic nerve that we have seen may not have do much of the IOP, but it is perhaps related to the IOP because subsequent follow-ups, if you see, the IOP is still high, even if the corneal thickness has come down to whatever level, but the IOP is still being recorded high. So that means high IOP is playing a component, and the earlier IOP which was recorded higher, but that might perhaps was even higher than that. Okay, so because patient has undergone LASIK in between, and there has been some follow-ups. So, but this actually is a very interesting story in this patient. So there are more than one actually points here. That one is to IOP, the other is to relate to that corneal thickness, and then you don't miss the key findings. There's the nerve fiber, there's disc hemorrhage which was resolving in the patient.
Other thing is if there is risk factor for glaucoma, the basic glaucoma workup need to be done prior to LASIK so as we have a baseline record. And IOP, apart from IOP, we should look for other risk factors for glaucoma and more reliable parameters like any structural damage in the disc and measurement, accurate measurement, and we should try if possible with other tonometers also, like tonopan which has a small diameter so that we can record away from the flap, or even if, with applanation we can record the pressure up gaze or low gaze so that to widen the area of the flap. And though DCT is advised and then clinically may not be possible, most of the people may not have that. And if we have a baseline pre-LASIK glaucoma workup, apart from IOP, presence of any other risk factor like family history or diabetes or history of steroid use, then they fall in high risk category. And if in case of moderate or severe glaucoma, where the LASIK is clearly contraindicated, and in mild cases, if the fields are normal, patient can undergo LASIK but with caution. And in case of multiple risk factors, better to avoid the LASIK surgery.
Right, so we do have a question, maybe Dr. Suresh, you can take that. So it says, as a general ophthalmologist, I come across cases with a high cup-disc ratio, with after complete clinical examination, fields, OCT, diagnosis remains doubtful. So if such a patient has a high cup-disc ratio and normal IOP, normal CCT and normal fields, is it better to start anti-glaucoma or better to observe? And also a single clock arc thinning on OCT. So in other words, clinically it looks normal, but the OCT flags red.
Yeah, thank you, Dr. Sushmita. Thank you, CS, for the opportunity. Can you hear me? I am audible?
Yeah, very much, sir. Carry on. Yeah.
Okay. We can hear you.
So the issue right now is commonly seen by all glaucoma specialists as well as general ophthalmologists almost every day. So we do see patients who have large cup disc ratio, which appears to a general ophthalmologist that it could be glaucoma. But if you evaluate the patient properly, do fields, check pressure, and do detailed examination, and other things may not be showing any changes. So as Dr. Pandav highlighted, it's not just cup disc ratio. We have to look at the size of the disc. So if it is a large disc, then large disc is likely to have large cup. So it may not be pathological. So it's likely to be physiological if you see large cup in a large disc. So don't presume that it's glaucoma patient. And
so we can safely say that even if the OCT has a single clock arc red, we use our clinical acumen also, and with normal fields and normal pressures, we usually don't treat the OCT, isn't it? We treat
definitely. So people start treating red. So red should never be treated, as Dr. Sushmita highlights in every talk. We should never chase red. So OCT is not the only thing, on the basis of which we start the treatment. So we have to see corresponding like disc changes, field changes, and only then we should go ahead with treatment.
Right. Thank you. I think in the interest of time, we'll move ahead. There are no more questions. The next, I think, is Dr. Sagarika. So you can come in, and her discussant will be Dr. Deepika at the end.
Good evening, all. I'm audible. Okay. Am I audible?
Yes, you are audible.
Audible, carry on.
Yeah, go on.
Okay. So my case is 54 years old female, and she presented in glaucoma clinic with chief complaints of decreased vision in both eyes since 1 year. So patient complained of gradual, progressive and painless decrease in vision in both eyes since 1 year. There is no any other ocular complaints. Patient was using glasses for distance and near since last 7 years. She was diagnosed as both eye primary angle closure in a private clinic, and laser iridotomy was performed 2 months back. Intraocular pressure documented was 16 mm of mercury in right eye and 18 mm of mercury in left eye that time. Patient is a known hypertensive and she is on anti-hypertensive medication tablet amlodipine. So there is no family history of glaucoma. On examination, best corrected vision in both eyes was 6.9. In right eye, it is with +1 diopter sphere, and left eye plus 1.25 diopter sphere. Intraocular pressure with measured with Goodman applanation tonometry. It was 21 mm of mercury in the right eye off drugs and 22 mm of mercury in left eye off drugs. Central corneal thickness in the right eye was 547 micron, and in left eye it was 550 micron. Anterior chamber depth was shallow. Anterior chamber was shallow with Von Harris grade 2 in both eyes. Iris patterns were normal in both eyes. There were no sign of any angle closure attack in either eye, and laser iridotomy was patent in both eyes. Pupil in both eyes were normal size, normal reacting. Lens was normal with no cataractous changes. On gonioscopy, pigmented trabecular meshwork was seen in 2 quadrants, and on indentation, trabecular meshwork was visible in all 4 quadrants. There was no synecdoche visible. Trabecular meshwork pigmentation was 2+, and there was convex iris configuration. This is the disc photo, both eyes. So these discs were diagnosed as non-glaucomatous outside, and she was diagnosed as primary angle closure. But here we can see the disc size and shape are normal in both eyes, and peripapillary vessel caliber is also normal in both eyes. But on careful examination, we can see there is shallow cupping in both eyes. So there is vessel bending, and both eyes are having shallow cupping. So here I have marked the cupping area, and further careful examination, we can see the localized retinal nerve fiber layer defect in the right eye. Here we can see here the localized peripapillary retinal nerve fiber layer defect, which is seen here in the right eye. So this retinal nerve fiber layer defect, this is more appreciated in the red-free fundus photo, and in the left eye, the normal retinal nerve fiber layer that are seen in as bright striations superior and inferior peripapillary area, but in the left eye we see these the bright retinal nerve fiber layer are not seen, so it's suggestive of diffuse RNFL thinning in the left eye also. This is the OCT RNFL picture, and on RNFL thickness map, we can see the localized retinal nerve fiber layer defect in the right eye superiotemporal part, and it is seen as blue color. So the thinning area is represented as blue color, and in the left eye, also diffuse retinal nerve fiber layer thinning is seen. So this is the deviation map, and the deviation map here, the superiotemporal, the red color, we can see the superiotemporal part, the red color is seen. So it indicates that this is found in less than 1% of normal age and sex matched control when we compare the RNFL thickness with the normal population. So and in RNFL thickness map, this is the double hump RNFL thickness map, we can see the loss of retinal nerve fiber layer in the superiotemporal part. So these are the visual field of the left and the right eye, and this is glaucoma progression analysis. And in the visual field of left eye, the visual field of both eyes were reliable, and we see the scotoma seen in both superior and inferior hemisphere, and in the left eye the scotomas are seen in inferior nasal part. So inferior nasal visual field defects are seen, and these are repeatable on 3 consecutive visits. So these inferior nasal visual field defects are well correlating with the superior temporal retinal nerve fiber layer loss.
So this patient was diagnosed as both high primary angle closure glaucoma, and we started topical prostaglandin analog in both eyes, and patient was kept on regular follow-up with 6 monthly disc assessment and visual field test. Thank you.
Thank you, Sagarika. I mean, that was a very illustrative case. Deepika, your take-home points?
Yes, ma'am. Am I audible?
Yeah.
I would like to thank COS and my mentors. So, in this case, I have 2 points to discuss. Like, first of all is careful disc examination. As Dr. Pandav sir has already highlighted that sometimes a very cursory look, disc may appear absolutely normal. But a systematic approach is required so that, and we have to make a habit to document the findings of optic disc size, shape, and we have to look at the cup shape and cup depth, and we also have to look specifically at the RNFL. And we can examine the patient on slit lamp only, and we can dilate the pupil if needed to examine the patient in detail, and because dilated examination gives good stereopsis and good idea of cup shape and cup depth. And we have to look at the contour cup, that where the vessel bend, second bend is seen of the vessels, that defines the cup limit. So a careful examination and RNFL should be seen very carefully, because unless we look specifically for the RNFL, there is high chances to miss RNFL defect. And red free light can be used on slit lamp also with green light to better see the RNFL defect. And decision to treatment in angle closure cases depend whether angles have opened after LI or not, and IOP level and the disc status. So if the angles are still closed, then we have to do iridoplasty. If angles have opened, then we have to treat the patient as open angle glaucoma, either ocular hypertension or open angle glaucoma. Then in this case, as the IOP level was little higher and there were disc changes and glaucomatous field defects, so the decision is to start treatment, and the first line drug is prostaglandin.
Right.
Thank you.
We do have, sorry, yes.
I think another thing, important thing to note in this case is that if you look at the optic disc, because this patient was like treated as a POAG, but it could have been actually very well treated like an NTG if the pressure was not recorded high. If you look at the optic disc carefully, it's not the usual cup that you see in POAG. There's a little shallow cupping, and there's the colors don't come out very well probably on the screen, but there's a slight, kind of paleness to these discs. Now, what does this mean? Essentially, is that if you optic disc like this, and you have an the angle closure, if you're suspecting angle closure, there's a possibility that this patient actually had an episodes of high pressure somewhere which clinically were never detected. But if you have high pressures which were happening intermittently, they can damage the disc, which is slightly different pattern of damage as you compare to the POAG. So this kind of a damage, I would suspect that maybe this patient had a high episode, maybe one high IOP episode, high IOP, or maybe even more, because this, the mild pallor with diffuse damage, kind of the disc. This is very often seen after an acute rise in IOP. So I think this disc actually also tells you, points you towards that kind of etiology in this patient.
So we have one question, I think, pertaining to the last one. Parul, maybe I'll get you in. What would you use for post-LASIK? That's a question that has come in. You're muted, Parul.
The post-LASIK anti-glaucoma medication?
No, post-LASIK eyes in IOP measurement. Which instrument? One instrument.
Applanation, Goldman applanation tonometer.
All right. So it's useful having a baseline and then having a thing later. Right, that was about the next one. I think in the interest of time, we better move on now. Dr. Aarti, are you ready with your slides, please? I think we'll have a discussion after that. Dr. Suresh will be her discussant. Aarti, are you on?
Yes.
Yeah, okay. So we'll have your slides.
Good evening, everyone. Today I'll be discussing case of a 55-year-old female who presented to the glaucoma clinic with gradual diminution of vision and watering from both eyes from 2 years. There is no history of any ocular surgery or trauma. The patient is a known case of diabetes mellitus type 2 and hypertension from 4 years, which was controlled on treatment. There is no history of any steroid use. The younger sister also has a history of glaucoma. The patient is a non-alcoholic and non-smoker. Coming to ophthalmic evaluation, the best corrected visual acuity in both the eyes is 6/6. The intraocular pressure on Goldmann applanation tonometry is 16 millimeters of mercury in both the eyes off drugs. The extraocular movements are full and free in all the direction in both the eyes. The lids and adnexa are normal. The pupil are of normal size and normally reacting. So coming to the anterior segment evaluation of both the eyes was within normal limit. The anterior chamber depth was Van Harry grade 3 in both the eyes. On gonioscopy, the angles were open in both the eyes in all the 4 quadrants. The posterior segment will be discussed along with the photograph. The central corneal thickness was 537 micrometer in the right eye and 547 micrometer in the left eye. The color vision of the patient was normal. These are the posterior segment images of the patient. Here we can see that in both the eyes, the media clarity is grade 1 and the fundus is tessellated. On detailed evaluation of the optic disc in the right eye, we can see that the disc is of average size, oval-shaped disc with a slight oblique tilt. The border of the optic disc is clear and well defined. The border of the disc is measured from the inner border of the scleral canal as indicated by the black arrows. Now, on following the trajectory of the vessels on the optic disc as indicated by the blue arrows, the cup to disc ratio was found to be 0.8. However, as we can see that the area of pallor of the cup was smaller than 0.8, which is suggestive of a pallor cup discrepancy, where the cup is larger than the area of the pallor. There was about 220 degree of peripapillary atrophy present in the right eye. On evaluation, we saw that it was an average sized disc with an inverted tear drop shaped with an oblique tilt. The border of the optic disc is clear and well defined. Here also there was a discrepancy noted in the terms of color, and the cup appears to be larger than the area of the pallor. So here we follow the contour of the blood vessels to determine the cup to disc ratio, which is depicted by the blue arrows, and the cup to disc ratio was found to be 0.8. There is thinning of the inferior neuroretinal rim noted in the left eye, and there is about 220 degree of peripapillary atrophy, which is broader inferiorly corresponding to the thinner neuroretinal rim. So we try to corroborate the clinical findings with the investigation, and the patient took several visual field analysis tests. The first reliable fields, as seen in the top pictures on the slide, was suggestive of quadrantic defects in both the eyes, which were again repeated after 2 months, and there was an element of learning curve which was noted in the right eye, where the visual field of the patient improved from the previous test. However, it was noted that in the left eye, the visual field defect appeared to have increased just over the span of 2 months. So, which suggested that maybe the fields were not that reliable in this patient. So we went ahead with the optical coherence tomography of the optic nerve head and the retinal nerve fiber layer of the patient. Here in the right eye, the average retinal nerve fiber layer thickness was found to be 79 micrometer, which was depicted by green, and in the left eye, it was found to be 73 micrometer, depicted by yellow. So this appeared to be normal. However, the fields and the OCT did not seem to correlate. The sectoral analysis on the OCT was suggestive of inferior thinning of the retinal nerve fiber layer, which corroborated with the optic disc of the patient. So we planned for the diurnal variation test of the patient, which was not found to be significant, and the patient was started on both eyes topical travoprost 0.004%. So as the visual field defects were approaching fixation on the central 24-2 threshold test, we decided to go ahead with a central 10-2 threshold test of the patient. Here we found that there was split fixation in the left eye and the fixation was paired in the right eye. The points of interest in this case are that the disc size, it has to be measured from the inner border of the scleral canal, so that the measurement of the neuroretinal rim is not fallaciously increased, and the cup size, it has to be measured by following the contour cup and not the color cup, and we have to be wary of the pallor cup discrepancy. The careful evaluation of the neuroretinal rim and the optic disc cup in tilted disc is important, as it can be difficult to identify the classic optic nerve head changes for glaucoma in these patients. Thank you.
Thank you, Aarti. Nice, interesting. I mean, these are cases which we all grapple with every day. Thank you, Dr. Suresh, for bringing this up. Your one take-home point, sir, before I throw it open.
So, thank you, Dr. Aarti. And it's an interesting case of NTG, relatively younger patient. Normally, we see it in quite elderly. She's 55-year-old. And disc evaluation, as Professor Pandav also mentioned, we should be careful because these patients have normal pressure. So if we miss the disc, we are likely to miss this patient and he may land up with irreversible loss of vision. So in disc evaluation, sometimes there can be cup-pellet discrepancy. So we have to keep that in mind. And diurnal variation must be done in all patients having pressure in the normal range, because sometimes there can be hidden peaks. So 10% of these patients can actually have POAG. So if DV shows there is no peak, then you confirm the diagnosis of NTG. And NTG patients, they can have comorbidities, hypertension, diabetes, thyroid disease, history of migraine, so many things. And some people say that it's a systemic disease basically, so NTG is part of the systemic disease. And as far as treatment is concerned, collaborative normal tension glaucoma study highlighted that even in NTG patient, 30% reduction of intraocular pressure may be beneficial. So, and prostaglandins are first line of drug because they are the only group of drug which can decrease the pressure even below the episcleral venous pressure.
And maybe we would like to avoid timolol once we've made the
diagnosis. Because nocturnal hypotension can worsen the disease.
Can I make a comment?
Yes, sir, sure.
Yeah, I think this is a well-presented case, Aarti, and this is a good case for discussion. I think I just want to comment that this patient actually has a significant amount of peripapillary atrophy. And that's the kind of atrophy which is associated with glaucoma. So sometimes it's very hard to say whether the peripapillary atrophy is associated with glaucoma or not. But if you look at this peripapillary atrophy, this is something very typical that you often see with glaucoma. It has those different zones, but important thing also is that PPA, which follows the optic nerve damage, that means there is a relationship in this. If you look more carefully, the PPA tends to be a little more, in terms of extent or in terms of its magnitude, more in areas where you have the rim is lost. So that there's a relationship between the PPA and the rim changes. So if you see there's some relation between the two, that actually is indicates that both the things are related to each other, and they have a cause or effect, whatever relation we don't really understand, but they are related to each other. So again, this is a very PPA in this patient is a very marked there.
Dr. Faisal, would you like to come in with one comment before we move on?
Yeah, I think the key is a good examination of the optic disc. That's itself important. And there is, if you diagnose a normal tension glaucoma, it's nothing to worry. There is no need to start the treatment at that time only. We can do a good workup for any other related systemic illness like sleep apnea, and I think that will be by Gaurav again. So that's my comment.
Yeah. So we move on to Dr. Gaurav then, and Dr. Faisal will be his discussant at the end. Dr. Gaurav, we don't have any new questions coming in, so we'll move on to the next one.
Very good evening to all. At the outset, I would like to thank CAUS for giving this opportunity to speak at this forum. So, I'll be discussing an interesting case of a 76-year-old female who was referred to us as a suspect on routine eye examination following both eye cataract surgery. So, patient was not complaining, was giving any complaints. On asking the history, patient was a hypertensive since 15 years and was controlled on medication. The medication she was using beta blockers, which she was using at night. There was no other history of any diabetic or hypertension. Diabetic or any cardiac history, and patient was not on any steroids. There was no family history of glaucoma. On ocular examination, the patient had a best corrected visual acuity of 6.6 in both the eyes, and intraocular pressures measured on applanation tonometry were 12 millimeters of mercury outflux. Here we can see both the corneas were clear and people were normal size, normal reacting. There was mild iris shaping. On slit examination, the patient had a wide peripheral AC depth, 1 and a grade 4. And on gonioscopic examination, here we can see the patient had wide open angles in the right as well as in the left eye. So we went ahead with disc examination, and on careful disc examination, here we can see in the right eye, the media was grade 1. It is a normal size, shape, and color. It was vertically bit obliquely tilted, due to which we can see there is inferior. It is appearing like there is thinning. So there was a vertical cup to disc ratio 0.7 in the right eye. Here we can see, and here we can see a very good amount of neuroretinal rim superiorly. And in the left eye also, this was normal size, shape. It was vertically oblique. The oblique insertion was more in the right eye as compared to the left eye. And it had a vertical cup to disc ratio of 0.8 approximately here, but on careful examination we can see superiorly there is a notch here, and on red free examination along this notch there is retinal nerve fiber layer defect as well. So the key point here I wanted to highlight was that in a case of obliquely inserted disc, we should carefully look at the neuroretinal rim, and we should look for this notch basically. So we went ahead with ancillary investigation. The CCT was low in this. The patient had CCT of 490 in both the eyes. We planned DVT, but patient could not come due to COVID. So we asked the patient to get a 24-hour blood pressure monitoring done locally, and for visual field, OCT and GCC. So on OCT RNFL here we can see, as clinically we were able to see superior notch, there was a superior RNFL thinning, and in the right eye also superior, there was borderline thinning, which was corroborating the RNFL deviation map as well as the thickness map. And similarly in the GCC also there was superior thinning, and the superior thinning in the left eye was corroborating with the inferior arcuate field defects. And in the right eye, there was superior RNFL was borderline thin, which was corroborating with this nasal step coming inferiorly. So there, the visual field effects were corroborating with the RNFL loss, which we were seeing. Now, this is a 24-hour BP monitoring which was done, and here we can see in the morning the blood pressures were almost normal, that is 140, 180, 110, 50. But at the night, that is when the patient sleeps and after taking a beta blocker, the blood pressure drops down to 90s, and the diastolic stopped down below 50, then 40, 45. So there is happening a lot of systemic hypotension at night. So they say that if the diurnal variation more than even 10, it is significant, and if the diastolic pressures drop more than 50, it is very significant. So this systemic hypotension in such a case is a very important factor. So we made a final diagnosis of both a normal tension glaucoma with systemic hypotension. Here I want to highlight another point, that DVT is of, as already discussed by the panelists, that it is of paramount importance as we might miss a spike. So DVT should always be done to diagnose a case of normal tension glaucoma. And other histories, like we work for systemic hypertension, other history should be asked of snoring or obstructive sleep apnea, because these conditions may also worsen the disease and cause progression of the disease if missed, even if the pressures we maintain normal. And other things of vascular occlusion like node phenomena or migraine should also be looked upon, as such things might be missed in a routine thing if we don't ask specifically. So in this patient, we asked the patient was advised to stop beta blockers, and medicine consultation was asked to alter the antihypertensive medication such that this nighttime hypertension should be avoided, and then the patient will be subsequently followed up on visual fields. So in such a case, I would like to ask for the panelists, like if the pressures are in the lower teens, like 12, so should we recommend decrease starting an anti-glaucoma medication in such a case, because how much increase IOP and how much that will benefit is a question for all of us, I think. Thank you.
Dr. Faisal, your take. Thank you, Gaurav. That was indeed a thought-provoking question.
Yeah. So a case like this, you have normal pressure and there is subtle changes in the neuroretinal rim and RNFL and the corroborating changes in the OCT, and the patient had underwent a phacoemulsification in the previously also. So before jumping into the treatment, just take a good history. If you have the patient have his previous record, actually we don't know what about the pressure recording after the cataract surgery also. Sometimes the patient can have a persistent myopia for a while, weeks or months after cataract surgery. That can lead to certain amount of structural and functional damage, then later on turn to be a burned out disease. So if you diagnose an NTG, then it is better always to get a good diurnal variation and also to get a 24-hour ambulatory blood pressure monitoring. As we know, in 2/3 of the normal population, there will have a 5% of diurnal dip at between 2 o'clock to 4 o'clock in the morning. So in the rest 1/3 of the population, either may be a low dip or a high dip. Low dip means there is 5% dip in the blood pressure, less than 5% dip in the blood pressure, or high dip means more than 10% of the dip in the blood pressure. So both these things are not good for perfusion. So all studies showed, most of the studies showed that if there is a high dip, there will be an increased chance of progression of the glaucomatous visual field defect. And indeed, in glaucoma, there is a decrease in the auto regulation of the peripapillary perfusion also. So both these, the systemic dip as well as the decreased auto regulation, lead to more ischemic changes in the normotension glaucoma. And other thing also, there could be an undiagnosed structure. Suppose if you have evaluated everything like carotid Doppler or sleep apnea and other history of migraine or any kind of peripheral vascular occlusivity, everything is negative. There could be some structural anomaly of undetected structural anomaly of optic nerve and lamina cribrosa, like poor structural support, like poor astroglial support the optic to the axons. That can also lead to change in the optic nerve changes in very low pressure also. So these things should be keep in mind. And of course, the treatment, I think should, if you diagnose the NTG as per CNDG trial, should treat better to treat, though the untreated arm also not 65% of untreated arm not progressive, but it's recommended to reduce the IOP 30% more from the baseline.
I think that's the important takeaway, that 2/3 of NTG did not progress in 5 years, and that's important. So before jumping into treatment, of course, like you said, I think we need to do a more holistic thing before we just start treating whatever pressures we get. Parul, one take, and then we'll move on.
I would like to observe for this patient till the time COVID goes and we do a DV. Once we are sure on the DV that there is a pressure higher than 12, then would like to start. But I guess till that time we can safely observe. A few months there or there won't really make too much of a difference.
Can I make a quick comment before we go to the next case?
Yes, sir.
Yes, sir, please.
Yeah, I think I just want to draw your attention to the optic disc actually, because this optic disc, if it is a right optic disc, if you're not careful, you will call the right optic disc actually is, having, inferior damage. But I think again, you must consider the anatomy of the optic nerve head before you say that there's a loss of tissue or not. And this is because this appears damaged because of the obliquity and because of the vertical tilt. So when there's a vertical tilt, the inferior rim will look like as if it's a temporal, like normally you see the temporal rim. So when you see the normal temporal rim, the neural tissue doesn't stand out very well because of the background is quite reflective. because of the obliquity of the insertion. And that's what is happening in this patient. And that is actually subsequently shown on OCT also, and even on the visual fields. So I think that's also a good point in this patient to, from clinical examination point of view, that the optic nerve head could sometimes be, appear glaucomatous, but may not be.
Yeah, so there are no more questions now. We'll move on. I think Dr. Amandeep is having a bit of a problem with his power supply. But anyway, we'll have Madhuri's presentation and then we'll see, we'll discuss it out. So Dr. Madhuri, please.
Yes. So good evening, everyone. At the outset, I would like to thank COS for providing this learning experience. Are my slides visible?
No.
Not yet. I think you'll have to share your screen.
Yes. Yeah. Are they visible now?
Yeah, yes. Visible. Yeah, carry on. Good.
Yeah. So I'll be presenting a case of a 53-year-old Indian female. She presented with the chief complaints of eye strain since 6 months, and she was referred for a routine fundus evaluation from the medicine OPD. Her significant history was of hypertension, and she was on tablet metoprolol twice daily dosing since 2 years. There was no other history of any other systemic illness or any family history of glaucoma. So her best corrected acuity was 6/6. On Goldman applanation tonometry, the pressures were 16 off drugs in both the eyes, and the corneal thickness was also 501 and 516 microns. So on anterior segment examination, the cornea was clear, the von Herrick was grade 4, and on gonioscopy, the angles were open. Coming to the disc picture, so in this disc picture of the right eye, the disc was about 1.9 mm in size, and on closer examination here, we can see an inferior notch along with a splinter hemorrhage at the inferotemporal margin. This was also corresponding to a RNFL, wedge-shaped RNFL defect, better appreciated on the red-free photograph. So coming to the left eye also had a disc size of about 1.9 mm, and this was showed a cup disc ratio of CDR 0.8. There was a laminar dot sign inferiorly along with an inferior notching, and a wedge-shaped defect inferiorly with few streak defects in the superior along the superior arcade also. So we went ahead with the fields, the structural imaging, and also we did a diurnal variation test on this patient. So the fields showed a corresponding, in the left eye they showed a corresponding defects in the superior arcuate fashion, and here we can see they are more closer to the fixation point. Even the right eye showed defects closer to the fixation point. So the RNFL showed thinning in the inferior quadrants. It was more in the left eye as compared to the right eye. Coming to the diurnal variation test, this patient showed a significant difference with an 8 mm mercury difference in the right eye and 6 in the left eye. So a diagnosis of both eye normal tension glaucoma with right eye disc hemorrhage and a grade 1 hypertensive retinopathy was made. So why do we call this normal tension glaucoma? There was cupping with corresponding visual field defects. The gonioscopy showed open angles, and the intraocular pressure was less than 22 millimeter of mercury at any point during the diurnal variation test. And there were no other features of any other secondary optic atrophy. So in a case of an NTG, it is very important to take a good retrospective history, because it is a systemic disease. We need to understand what are the factors, whether it is optic nerve head hypoperfusion, any carotid stenosis component, or any blood hypoxemia, or any peripheral vasospastic disease. So there was no history of any migraine, hypertension, any hospitalization or blood loss, any dizziness, syncope, or cold hands and feet. There was no history of any obstructive sleep apnea or carotid artery disease. Her only significant history was for hypertension, which was controlled on tablet metoprolol, and she did give a specific history of twice daily dosing with having one dose at the bedtime. So, suspecting optic nerve head hypoperfusion, we did start the patient on a prostaglandin, and we referred the patient to an internist to look for other vascular factors, mainly nocturnal diastolic hypotension, by a 24-hour BP monitoring. So this was 2 months later, the hemorrhage resolved. She was shifted to ACE inhibitors at this point of time, and her beta blockers were stopped. The RNFL defect appeared to be in a similar size. However, 7 months later, here we can see a progressive increase in the notching, showing the comparative photographs. So this is the this was at the time of disc hemorrhage. Here we can see the notch with the rim, and here we can see the rim has subsequently thinned out in this area. The left eye remained stable. The fields of both the eyes were similar and stable, and the OCT RNFL was also stable. So the further plan for this patient is to have IOP monitors and OCT RNFL done 6 monthly, and we need to even keep in the mind that hypertension is a very important coexisting pathology with normal tension glaucoma, and this needs to be monitored, and we need to check for any nocturnal diastolic dips which could cause which could be potentially compromising the optic nerve head hyperperfusion. Thank you.
Thank you, Madhuri. Is Dr. Aman able to log in? Right. So, Dr. Faisal, you can carry on with the discussion of this. It's similar to what we had discussed, and then we'll call in Dr. Suresh to give his comments to this case.
I think to see the progression, if it is rapidly progressing, always think about other pathology rather than IOP, because that is because IOP is not the only factor for responsible for glaucomatous changes. Some other factor will be there. So always think about that other than IOP if it is progressing very rapidly.
Ma'am, I have one quick question. Like when we say diastolic BP monitoring, so is the position of the patient where we take the blood pressure recording also important?
Yeah, it's really important, because the recommended this 24-hour ambulatory IOP, because there is a Holter method. Even patient may not aware about, even some people are taking his blood pressure. That is very important. And also there is if you possible you can take a should keep the diastolic perfusion pressure, because DPP, that is diastolic perfusion pressure, should not be less than 50, always should not be less than 50.
Which is the diastolic BP minus the intraocular pressure.
Intraocular pressures.
Dr. Aman, welcome back. Your comments, please.
Yeah.
Your comments, please. We are waiting for the case, for Madhuri's case.
Well, it was commendable to have diagnosed glaucoma in a case which patient comes just with the eye strain as the chief complaint. So again, it's good to have a good look at the discs, and you dilate the pupils, you see the RNFL defects. That was the message, I think.
Yeah, right. Dr. Suresh, any last comment before we go on to the final case of
the interesting thing was we were able to see change in disc structures. So there was structural functional disparity. So sometimes in some patients we have early structural changes as compared to functional changes. So we should not always look for functional changes. Structure can precede, structural progression can precede the functional progression.
I think another interesting thing here is that the OCT is actually not showing any progression. So if there was a true structural change, the OCT should have picked that up, isn't it? Because if there is a structural change that is visible to your eyes, why it's not visible to OCT. So I think that you need to ponder over that. To some extent, I would like to go back to those images again and look for one parameter. You don't have to put them back, I'm just saying. So I would look for parameter is the brightness of the image, is the brightness comparable? Because if one image is too bright than the other, then the brighter image will give you an impression that your neuroretinal rim is on the thinner side or has thinned out. So I think you have to keep that in mind before you say on an image that the rim has thinned out. So if you have ruled out that factor, then only you will be able to say that, okay, this is truly nerve thinning. So especially when OCT is not picking up that change. I'm not saying that OCT is actually super sensitive in that, but the issue should be kind of thought about and discussed, and should come to your mind that why there's a discrepancy in the two.
So can the patient had hemorrhage also in the same area? So could hemorrhage lead to some edema, and which can...
I mean, that's a logical sequence that you have pointed out rightly, because once we have a hemorrhage, that area usually undergoes a structural change. Absolutely. That's true.
Dr. Parul, this is an extension to your comment. There's actually a question. How will we do diurnal variation in COVID times, and how many times a day should IOP be taken to get a fair idea of the diurnal variation?
Well, we hope the COVID time passes soon, and at least we can wait till the time COVID passes. I would not unnecessarily like to subject somebody to this test right now.
Dr. Faisal, since 2 or 3 of them were all NTG,
I think,
what would you do today? I mean, we have no idea, assuming COVID is not going away till next year. What do we do?
I think it's better to call the patient at different time, at least in the daytime. If you examine one day in morning or 9 o'clock, just shift the patient next appointment in the afternoon or at the end of the day. At least you will get some idea of the fluctuation.
Okay, would it be a good idea to just let him wait for a day and take it in the morning, afternoon, evening, at least in one shot, one visit, you have some idea? Would that be all right? I don't know. Harsimran has asked that, so Harsimran, all of us have our own reservations really. And if you look at the disc and you're very, very suspicious, or you think, I think relying on a disc and visual field should be all right as well. Thankfully, glaucoma is not an instantly blinding thing, so another 6 months of maybe no diurnal may tide us over. We hope that, right? So, well, no, there's nothing else. Okay, so we go on to the last of the day, Dr. Ekta. Are you ready with your slides, please? And her discussant will be Dr. Parul at the end. Dr. Ekta, are you ready?
Yes, ma'am.
Yeah, come.
Are my slides visible?
Yeah.
Okay. Good evening, everybody. I would like to thank COS for providing us this with learning platform. I'm presenting a case of 47-year-old female who presented to our OPD with the gradual diminution of vision for the past 4 years. She was diabetic mellitus type 1 for past 6 years as was on treatment, but she had a labile profile. Her ocular and family history was unremarkable. On visual examination, she had a best corrected visual acuity of 6/36 in both eyes. The color vision was normal in both eyes, and so was the central corneal thickness. The intraocular pressure, as measured by Goldman applanation tonometry, was 18 mm of mercury in right eye and 16 mm of mercury in left eye of the drugs. The pupillary reaction was ill-sustained in both the eyes. The rest of the anterior segment examination was within normal limit with clear lens. The gonioscopy showed open angles. The mean ocular perfusion pressure in right eye was 50 mm of mercury, whereas in left eye it was 52 mm of mercury. On fundus examination, she had an average oval disc. In right eye, the vertical cup to disc ratio was 0.85 with neuroretinal rim pallor with thinning of the inferior rim, whereas in the left eye, The vertical CDR was 0.7 with neuroretinal rim pallor with 270-degree peripapillary atrophy. There were no signs of diabetic retinopathy. The optic disc cube 200 by 200 scan on SD-OCT showed flattening of humps in all the quadrants with significant flattening in the temporal quadrant. There was thinning of the superior and the inferior quadrants. The macular ganglion cell analysis showed marked decrease in the thickness in all the quadrants of both the ganglion cell layer as well as the inner plexiform layer. The patient had many unreliable fields. One of the reliable 24-2 fields in the right eye showed incomplete biarcuate scotoma, whereas in the left eye, the defect appeared to be along the vertical meridian, but it was not approaching the fixation. Now, since our patient had a decrease in the visual acuity with pale disc, it made us to think on the line of non-glucomatous optic neuropathy. Our patient fulfilled the Greenfield criteria for the non-glucomatous optic neuropathy. Hence, we went ahead with a neurological examination and contrast-enhanced MRI, which were both unremarkable. Our patient had a ocular perfusion pressure in the borderline, so a carotid Doppler study was done, which was also within normal limit. The diurnal variation showed an intraocular pressure of 6 mm in right eye and DVIP variation of 7 mm in the left eye. Keeping in view the clinical findings and the OCT and neuroimaging, the following possible diagnosis came to our mind, that is normal tension glaucoma, non-arthritic anterior ischemic optic neuropathy, Leber's hereditary optic neuropathy, and toxic neuropathy. Our patient best befitted the profile of the normal tension glaucoma since the patient was started on travoprost OU in both eyes. The patient had well-controlled IOP and stable fields on the last follow. The major concerns with this case was our patient had disproportionate vision loss since the patient was young and had a clear lens. The pallor of the disc, which could be accounted by the ischemic insult, and was the visual field defect in the left eye respecting the vertical meridian, and lastly, could it be a case of an atypical normal tension glaucoma? Thank you.
Thank you, Ekta. That was really interesting. So, Parul, your take.
Pallor in this case was very disproportionate. So since the cupping also looked very concentric, so it pointed a little bit more towards the non-glaucomatous optic neuropathy. But the OCT sort of helped us to remove our doubts a bit because it was the inferior and the superior sectors in the OCT that were more markedly muted as compared to the temporal quadrants which we would have expected in a non-glaucomatous optic neuropathy. Was that the macular parameters on the OCT were very markedly reduced, which again suggested more towards compressive sort of a lesion. So that was a little bit of dilemma, but the DVIOP, since it was borderline, so we preferred to consider it as a normal tension glaucoma rather than a non-glaucomatous one, and none of the other findings, be it the imaging or the Doppler, they were contributory. So sometimes the pale optic neuropathy can make us err on the side of non-glaucomatous optic neuropathy, wherein it is actually an NTG. So the pallor was something which was a little confusing. So,
can I make a comment?
Absolutely.
I think there are a couple of issues in this patient. You said this is a young. How was the age? I think probably I missed that.
47.
How much?
47.
Okay, so 40. That's a young patient for that kind of a day. So definitely this is a young patient. Other thing I noticed was that if you look at the optic disc, definitely this is a pallor. But the neuroretinal rim, which is present in such, certain areas in the periphery, that is also pale. So if you have a rim which is visible otherwise and it is pale, that is something which is a very strong indicator that it might be a non-glaucomatous problem, right? In a glaucomatous eye, the rim which is lost, but which is left behind, that doesn't look, that doesn't have this kind of a pallor. So a young patient with a pale rim, neuroretinal rim which can be identified but it's pale, these two factors, and the presentation was with the gradual loss of vision. right? So the loss of vision, pale disc, young patients. So there are three factors which are actually against the diagnosis of glaucoma, right? And these are the factors which would warrant a neuroimaging for this patient. So I probably missed, how was the visual field in this patient?
So the right eye had an incomplete biarcuate defect, and in the left eye, the fields sort of seemed to be respecting a vertical meridian. So
Okay.
since
So the field was also, I would say, so I would put it this way, the visual field was also atypical, at least in one eye, right? So that's another point which actually gets added to the first three ones. So there are a lot of odds for this patient to be a glaucoma patient. And even if is a glaucoma patient, I would suggest a neuroimaging for this patient because
MRI was done.
it strongly points towards a compressive pathology. It may not be vascular because there's no other evidence. Even patient is diabetic, but there's no other evidence for any vascular pathology. The retinal vessels otherwise look good. There's no arteriosclerosis visible. And if it's a vascular phenomenon, if there's a like AIU and kind of thing, that the disc is really pale, it's white actually, it's not even pale, it becomes white. So that kind of pallor is not seen in this patient. So my take would be that this is, I would still consider it, compressive pathology in this patient. We have to rule that out. It may not be there, but we have to rule it out. And that doesn't look like AIUN, and it doesn't look like glaucoma, right?
The contrast enhanced MRI was done, which was normal. A carotid Doppler was done, which was normal. The patient was evaluated by a cardiologist, and he could not find any finding.
So that's good. So if there is nothing was found, then you can actually call glaucoma. But there are a lot of atypical things in this patient for glaucoma point of view.
Could it be an old insult, Parul, an old AION or an old insult which is just there? If the pressures are not so high, can we just observe it and see what happens rather than treat? What do you think? Because the pressures are not too high either.
I did start on treatment after I found that there was no cause which was contributing to the ischemia, and since there was focal areas of peripapillary atrophy just adjoining the neuroretinal rim thinning, so I thought that it's better to start on treatment. So, and since the diurnal variation was also borderline, the difference being around 6 and 7, so my take was to start on treatment, but
I think looking at the amount of damage that has already happened, because this much of damage has happened because obviously the disease has progressed. Whatever it is, it has progressed over a period of time. That's why there's so much damage is already there. So if the visual reserve, the functional reserve is already low, I think it's better to put on treatment. So because now you don't want to take any risk. Sorry.
Sorry, Parul, carry on.
She's a diabetic, so I thought that probably her vascular hemostasis is also compromised. So better to start on treatment. That was my thinking process.
Sure.
Patient is relatively young. Patient still has lot of years to live, so I think it's better to treat rather than keeping under watch.
Okay. So we have this case scenario which has come up, so I'd like everybody to put their heads to it. So there's a young patient, we don't know what the age is, with the right eye 0.4 cup, left eye 0.8, vision of 6/6, both eyes, and IOP is 14, and diagnosed as right PACS, left PACG after gonioscopy, fields and OCT, both done. Now there are open angles after PI, so we assume the angles were closed before. IOP is 14 still. No treatment in the right, but on a PG analog and beta prim. So 3 drugs in the left, and the IOP didn't fall after PI. 10-2 has become involved and is stable over 2 months. Advice trap for the left eye. Could the cause of progression be secondary like hypoperfusion, as patient has history of migraine? In other things, I think we're thinking in terms of a mixed mechanism glaucoma, because we assume that the angles were closed and then they've opened up after LI. but pressures haven't changed very much, and it says progression, but it doesn't say why it says progression. But so mixed mechanism glaucoma, mixed mechanism normal tension and PACG. Sir, your take first. Does that happen in a young patient? Is it possible? So you're muted. Dr. Pandav, you're muted. So you're muted.
Yeah, okay. I think it's a known entity, like some people do have a mixed mechanism of glaucoma. But in this patient, it's a young patient basically, and the one eye is more involved than the other eye, and there's evidence to say the glaucoma earlier because laser iodotomy has been done. So this is not very unusual to see this kind of picture in angle closure glaucoma, because angle closure glaucoma is very asymmetric at times. The one eye may be completely normal and the other eye can be very advanced. So that can happen. So that's not unusual for angle closure glaucoma to happen in this patient. So now the issue is that the IOP is still not controlled in that eye, and angles are open. So because angles are open, they are not physically closed. So that's where the question of mixed mechanism is actually coming in. But it is also said that if you have a raised IOP or acute rise in IOP, or the angle was closed before laser iodotomy or before treatment for a some time, then the angle may be less functional than it should have been. That thought is also there. But if the angle is completely open 360 degrees and still the IOP is not controlled, I think then it's reasonable to say that maybe something else is also happening there. So it could
because
be
the IOP, at least the scenario that has been sent, the pressures were 14 before LI, and it's still 14 after LI. And she's still on 3 medications before and still on 3 medications after. So I think that is.
So we haven't really tried taking off the medicines, that means?
It was 14 and it's still 14.
Because sometimes it happens, because even the 3 medicines are on, it sometimes happens that if you remove the 2 medicines and just keep the one which you think is most effective for this patient, and just keep that medicine on, and you will be surprised that IOP may not actually go up. It may still remain controlled. So if that has not been done, maybe we could even do that.
Would it be secondary angle closure?
Secondary angle closure in one eye. Okay. Oh, that could be a thought. I presume if LI was done, so it must have been it's PACS, PACG, so I don't know. So that could be one thing. Right. So the patient is 38 years old. So that has come in now after the discussion. So I think there are 2 more things that we can for the audience, because it's on our chat. One is, how commonly do we find disc hemorrhages? Dr. Suresh, how commonly do you find disc hemorrhages? That's a question. And if you find a disc hemorrhage, I thought that is very interesting. Should we wait for investigations or should we start treatment? So if you see a disc hemorrhage today, is there any need to do peels and all that before starting treatment, or you can start treatment and just do the investigations as a baseline and then follow up?
So disc hemorrhage is seen more commonly in normal tension glaucoma patients. So studies have reported it to the tune of up to 40% or even more in NTG, and in POAG it's less common, maybe less than 10%. So we do see disc hemorrhage in our patients. And if it is a well-established patient of glaucoma and we see disc hemorrhage, so this points to the fact that maybe disease is progressing. So then you have to change your treatment, add on another drug depending on other factors like intraocular pressure and visual field changes. But if you are seeing patient for the first time and patient is having disc hemorrhage and other changes also, then you have to investigate the patient for glaucoma, look at the disc, look at the fields, OCT, and correlate them clinically. And if you have structural functional changes, both are there, then probably you diagnose it as a patient of glaucoma and start treatment. But if it in a well-established glaucoma patient, it points towards the progression.
Right. And
I
think the question was, suppose we just saw a disc hemorrhage.
Yeah, if you can make a
Should
comment.
we just start treatment, or should we also wait and investigate and see whether it's glaucoma?
Can I make a comment?
Yes, sure.
Yeah, I think here there is an isolated disc hemorrhage. So it depends what else you are seeing with the disc hemorrhage. So if the disc is absolutely normal, there's no evidence of glaucoma, like the neuroretinal rim is good, there's no loss of neural tissue. Disc hemorrhage could be non-glaucomatous. I think that also you have to keep in mind. And the most common reason for that would be a PVD. So sometimes the PVD, when the detaches, so if you have a PVD of a recent PVD that has happened, you could assess from the symptoms or from the patients, you can investigate. So that could be the reason for a non-glaucomatous hemorrhage. Sometimes the hypertensive, diabetics, and people who have blood dyscrasias, or what kind of rheological disorders, they can also have disc hemorrhages. Though the isolated disc hemorrhage, very typical of a glaucoma, which is crossing the disc margin and on the neuroretinal rim tissue, that's very characteristic. So unless proved otherwise, you take that it might have something to do with glaucoma. So having said that, if there's no other change, if the disc hemorrhage is associated with something else, like if there's a small notch in that area or there's a corresponding nerve fibrillary defect, then there's no doubt about the diagnosis. There you could treat without waiting for the investigations. But in the absence of any of those things, you would like to do the basic investigations and then start, because again, there's no emergency for treating. Even if it's a glaucoma, the IOP is normal, there's actually no emergency in treating, so you can always wait, you can always investigate. But this does need, a disc hemorrhage of this kind does warrant a thorough clinical evaluation as well as some investigations to establish a baseline for glaucoma, whether you treat or you don't. Yeah. So there's no emergency for treating. Yes.
So also the disc hemorrhages, they are waxing and waning. So you have to document. If you are seeing disc hemorrhage today, next visit you may not see it. So that had to be documented so that it's a baseline for other whosoever examines on the next visit.
So I think the last question on the chat is, what is a water drinking test? Can it be used as a, so Parul, back to you. Water drinking test as a substitute. So just make your patient drink 2 liters of water and check. Would you use that as a substitute for a diurnal variation? That's the question.
No, ma'am, I wouldn't do that. Because it has also been said that too much of water in one go anyway leads to rise of pressure. And in 2 ages, anybody has advocated it as a substitute. So might as well do a office DV which is very dispersed over a period of time rather than giving somebody such a big bolus of water.
Dr. Suresh, I'll take everybody's comments for that. Dr. Suresh, Dr. Faisal.
I agree with Parul that we should avoid giving large amount of water.
No, the question is, would you?
And I will not.
Okay. As a substitute for a diurnal.
No, I won't like to use
time
this.
thing.
I will prefer doing diurnal variation rather than giving water.
Faisal, good idea?
I don't.
You don't follow. Sir, what would you say?
I don't think, because this water drinking test has been there for a very long time and has been investigated many times, but there's no conclusive evidence that it helps in diagnosis of POAG. Overloading of water does lead to some increase in IOP, that's known, but is it kind of diagnostic of POAG? It's not. Because a small rise in IOP after water drinking test, it doesn't really indicate that prove that, or is not a strong risk factor for development of glaucoma. So there's not much association has been found. And similarly, negative IOP, water drinking test doesn't mean that the person cannot develop glaucoma later on. So there's no evidence to say that water drinking test helps in early diagnosis of glaucoma. And that's for open angle glaucoma. In fact, people have tried water drinking prone test also for angle closure glaucoma. So you would do the double, you have the prone patient where the lens iris diaphragm moves forward and you also have a water drinking. Even there, there's no evidence to suggest that any of these provocative tests are used for glaucoma. So as of now, none of the provocative tests is actually recommended for, as a test for glaucoma, for early diagnosis of glaucoma.
Thank you. I think we've overshot our time by quite something. I think I'll hand it back to Kos to wind up, and thank you very much. It's been a lovely session to have together.
Thank you, everybody. Yeah, I think we had a good discussion. It was great. Good cases, actually, because all presenters were good. Yeah, everyone presented very well.
So thank you, ma'am, and thank you everyone for what was a very interactive and a very interesting webinar, even for a person who's not a non-glaucoma person. And I'd like to take this opportunity to thank all the panelists as well all our presenters for excellent cases. And I think the point that Professor Pandav made in the beginning, that all of us need to be sensitized to glaucoma, whether we are cornea specialists or retina specialists, is something we should be taking away from this webinar. I'd also like to thank Sun Pharma for supporting us with the IT, which has been, I think, extremely smooth, and a special thanks to Rohit for that. And once again, I thank you all, and we look forward to further such webinars. Thank you.
Thank you, ma'am. Thank you.
Thank you. Thank you.